Welcome back to Dyslipidemia Management 2014. Views on the News. These are contemporary discussions on the topical news of the day. It's presented by Northwestern University Feinberg School of Medicine. You are tuned in to today's second session entitled New Directions in Lipid Management. My name is Dr. Claude Yancey, and I'm Chief of the Division of Cardiology at Northwestern University Feinberg School of Medicine. I'm pleased to serve as chair for this important educational program and as co-chair for CardioCare Live. For those of you just joining us, today's session is a live, interactive program that allows us to take questions in real time from you throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located in the lower left-hand side of your screen. Let me set the stage for today's discussion. I'm delighted that Dr. Michael Davidson, professor of medicine and a diplomat of the American Board of Lipidemiology, who is director of the Lipid Clinic at the University of Chicago Pritzker School of Medicine, is here today. Michael, thank you for joining us.
Thanks,
Delighted to have you here. To set the stage, we just had a very engaged conversation with Jennifer Robinson and Donald Lloyd-Jones talking about not only the new cholesterol treatment guidelines that supersede ATP3, if you will, but also talking about the risk calculator. And we made some very relevant points. We emphasized that we've taken a very clear evidence-based approach. We've emphasized that treating to goal numbers is not the emphasis now, but lowering ASCVD risk is important. We've identified several groups where there's incontrovertible evidence, greater than 2 randomized trials, that it works. People that already have established cardiovascular disease, those that have a familial dyslipidemia with an LDL greater than 190, the diabetic patients between 40 and 75. And then we talked about the primary prevention group and really honed in on the risk calculator to understand that if a patient's risk estimate is at a sufficient threshold where the number needed to treat far exceeds the number needed to harm vis-a-vis statin therapy, then we should proceed with either moderate or high intensity statins. So a lot of useful information that our audience received, a lot of great questions about the integrity of the evidence, operationally, how do you do this? And everyone's beginning to get it, that this is a new paradigm. I love what Dr. Robertson said. Think of this as updating the treatment paradigm and in developing a therapeutic relationship with your patients. So let's say we've covered a lot of territory already, and where we want to go now is what's next. And your task is to talk about the new, the novel, the different, and you've got some really good stuff here. So Thank you for being here. Let's begin.
Yeah, thanks, Clyde. So I think that, like you said, this is really the minimum we need to do to reduce cardiovascular risk. But what about the future? What about the individual patient that might have other factors? And that's what I want to try to talk about today. Here are my disclosures. So let me give you 2 examples. This is Clark Gable with Joan Crawford. 1960, he died of a MI at age 59. That was one of the peak years, actually peaked 1973. 80% of Americans smoked. Cholesterol levels, the mean LDL was about 160. Hypertension was rampant. So risk factors, drove significant cardiovascular disease. We fast forward to 2008. We have Tim Russert, unfortunately, an example of someone who today's guidelines, even ACC/AHA, he's appropriately treated with a statin, but yet dies prematurely of heart disease. Right. Yeah. So what do we do about the Tim Russerts, which represent kind of the unmet medical need when it comes to further risk reduction? Tim Russert, by the way, had high triglycerides and low HDL, but had an LDL on a statin below 70.
So Michael, you really make a great point, and it's a nice extension to the earlier discussions. The guidelines as we know them were not ever meant to be universal or to capture all persons with all degrees of risk. There are persons over the age of 75 that have events, people on the age of 40 have events, and even those that are treated to target, if you want to take the older paradigm, still have events. And so that makes this conversation so timely.
Right. So when we think about LDL first, and that is the strongest kind of modifiable lipid parameter that we have evidence before, So to summarize the guidelines from my perspective is that we have high-risk patients. Statins are the first treatment. More statins better than less statin for high-risk patients. But I think probably the most paradigm-changing aspect of the guidelines was focusing on risk primarily and less on LDL targets. And I think that's going to make a difference because we were treating patients with LDLs that were very high but at low risk, but avoiding treating or not treating patients that had LDLs below 100 that had very high risk. So I think from my perspective, that's an important advance in how we look at addressing risk in our patients. But I believe in the LDL hypothesis. I believe that lowering LDL to a lower goal is going to provide additional value. Now, can we prove that? That's where some of the new ongoing therapies might ultimately try to show that convincingly, that on top of a statin with further LDL cholesterol lowering, we can really get even greater risk reduction in our patients.
Michael, you said that with such conviction. I believe in the LDL hypothesis.
Right. I'm going to go to my grave believing that. I really will.
So let's keep going.
So when we think about new options to consider, I think what's really exciting has been the genomic revolution and thinking about all the gene targets that have been identified through genome-wide association studies, GWAS trials. And that's opened up a lot of new targets of therapy. The one that I want to focus on today is PCSK9 and how that led very quickly to a new therapy. What these slide shows is there's a lot of targets out there that GWAS trials can either validate or invalidate. In other words, the surrogate looks promising, but the GWAS trials don't support a benefit for that surrogate. And let me give you some examples. But before I do that, I want to talk about the unmet need.
Okay.
So statin intolerance,
Okay.
Refractory hypercholesterolemia, hypertriglyceridemia, leading to elevated non-HDL cholesterol, very low HDL cholesterol, elevated LP(a), and then as a cardiologist, one very important patient type that we see is those that have progressive atherosclerosis despite being on maximal statin therapy.
Right.
So here's the GWAS data. The GWAS data has now shown well over 100 genes associated with lipids. All the LDL genes are linked to cardiovascular outcomes. Either when LDL is high, risk is high. When LDL is low, risk is low. HDL, it's not so clear cut. High HDL genes, not always protective. Low HDL genes, not always associated with increased risk. But now new evidence suggests that triglycerides are linked to cardiovascular risk, perhaps equal to that, if not more than LDL cholesterol. So that's a very interesting new development when it comes to how we look at triglycerides as being causal for atherosclerosis. So let's talk about the PCSK9 story for a second. So PCSK9, genetically, loss of function, very low LDL, very low cardiovascular risk, gain of function, very high LDL, very high cardiovascular risk. So we have an example where genomics has centered in on PCSK9 as an important target of therapy. So here's how it all transpired. So the first identification of PCSK9 was in the early 2000s. Knock-in, knockout experiments validated the target in animal models. We developed plasma levels to check PCSK9 assays. Human trials showing loss of function, high LDL, low LDL rather, gain of function, high LDL, linked to cardiovascular risk. And then as we move forward very quickly, now we have human data on an antibody to PCSK9 that we may have available for FDA approval early next year or late next year, depending on the regulatory pathway for this compound. So here's the ERIC trial data, actually the Dallas Heart Study data that showed that when you have low PCSK9 levels, you have very low levels of LDL, and almost no heart disease. This was African